Good afternoon, everyone. Um, I would like to make a few announcements before we start. I have muted everyone's microphone. Please ask questions via the chat function at the end of the talk. I will read as many of them as I can for Dr. Hamm to answer. I will also display the Get Credit code at the end of the talk and put it in the chat. Our speaker today is Dr. Joel Hamm. Dr. Hamm earned an MD at the University of Kentucky College of Medicine. He completed an emergency medicine residency and international emergency medicine fellowship at the University of Alabama at Birmingham. As part of the fellowship, he completed the Gorgas Diploma course in clinical tropical medicine in Lima, Peru, earning the Diploma of Tropical Medicine and Hygiene. He has also studied tropical medicine in Thailand and Cambodia and provided medical care in low-resource settings in Kenya, Jordan, El Salvador, and Gambia. He completed an MPH at Western Kentucky University. At UK, Dr. Hamm attends in the emergency department, leads the Global Emergency Medicine Fellowship, works in the Global Health Initiatives Office, and serves as the COVID-19 Emergency Department Medical Director. Today, Dr. Hamm will give a talk entitled COVID-19 ER Protocols. Welcome, Dr. Hamm.
All right, thanks a lot for that introduction, Kim. As stated, we're going to talk about the preparedness plans for the emergency department here at Chandler Emergency Department. Just remember, we're on the front lines with everything going on. The ER mantra is anyone, anytime. So we just got to keep that in mind, that we're really getting prepared for everything. In Kentucky, I think we've got a little bit of an advantage here because we're a rural state. We've had some public distancing protocols and the guidelines implemented a lot sooner than other states. So we're definitely at an advantage moving forward. But with that time, we've got to use this time wisely. So I'm just going to present what we're doing and how we're preparing. So the goals for our preparation, maximum efficiency and throughput. So this is the idea that at peak volumes in our emergency department, we could be actually seeing and making disposition decisions within 10 minutes at a time. So we've got to figure out a way to maximally get our patients through the ER and to the right location. We got to do this accurately. We can't miss patients who have COVID-19. Protect our healthcare workers. This is going to be a big theme of what I'm talking about today. And moving forward, you guys will see that this is a key issue. Protect our patients. We've got to protect our patients. We got to meet the needs of all of our patients, including stroke patients, MI patients, patients who otherwise don't have COVID-19, but we got to think about their needs as well. We've got to preserve PPE. Dr. Newman's town hall this morning reminded us that we're going through about 3 months of PPE supplies within 1 week. So preserving PPE is especially important. And finally, the concept, as we all know, of mitigation, flattening the curve, slowing down the spread of the virus, decreasing the surge so we don't have our peak volumes all at the same time. So I think those are our overall goals. If you look over to the right of the screen here, you'll notice the up-to-date Kentucky numbers, 12,000 tested, 770 positive, including 31 deaths and 11 deaths just recently. So we appear to be starting on the upslope, but definitely not on the towards the peak at this point. So this is a challenge from Lombardy region in northern Italy. So they said the biggest risk, there remains a risk of collapse of the healthcare system is due to difficulty in triage, allocation, and shortage of high-level care beds. So in the emergency room, we can really affect this a lot, especially on the triage end of things. And that's really what I'm going to be focusing on a lot during this talk. So some of our preparation in the emergency department, we talked a lot about testing, discharge and disposition. How do we handle these patients? Well, there's this concept of forward triage. So moving the point of primary contact farther away from the hospital, farther away from possible contamination of healthcare workers and also other patients. And then we'll also talk about the idea of setting up your emergency department as a hot zone versus a cold zone. And we've done that in the emergency department with our respiratory pod zone, and I'll explain that. Telehealth in the emergency department. This is exciting movement that we'll get to talk about as well. And then I'll briefly touch on airway management, because this is the highest risk procedure. If you look back at the SARS data especially, this is the one that you really want to be the most careful on. So this is from the Institute of Health Metrics and Evaluation. As Dr. Newman alluded to this morning, there are actually more accurate models for Kentucky at this time. So we've got models now predicting a peak more early June, mid-June area. So especially if we continue to flatten the curve with social distancing, things like that. But this model is available for previewing on the internet. This is a big theme of what I'm going to talk about today. So minimizing healthcare worker infections. If you looked at this original review from 138 patients that were initially infected in Wuhan with coronavirus, you'll notice that 29% of the initial Wuhan patients were healthcare workers. That's a scary number, but it's also something that can prepare us more moving forward. If you also look at the Italian data, I've seen numbers of around 10% are healthcare workers, and Spain was around 15% was the numbers I saw. So this is significant, and I think this is something that needs to be on the forefront of our minds moving forward. So what we've done in the emergency department is set up a screening algorithm, and this is outdated already because things move so quickly. We use the CDC criteria of fever, objective or subjective, plus cough or shortness of breath for our screening algorithm. We had an automated system already set in place to screen patients for hepatitis C. And with that, we were able to move very rapidly towards setting up the COVID-19 screening as an automated test. So we did this, and I'll show you some of our data from that. If you look to the left of the screen, if a patient just needed swab and go, they would actually be discharged quickly. The pharmacist, we have an outstanding group of pharmacists in the emergency room department, and they would actually make the callbacks for the patients. In the middle group was indeterminate disposition, and then on the right side is like patients who needed to be admitted. We actually stopped doing the CT chest once we got the lab's ability. So this was kind of all a work in progress at the time. And at this point, we've started using CT chest for making decisions about COVID-19. If you remember the Hong Kong and Singapore experiences, the screening is one of the most important things, screening and identifying these patients rapidly, just to slow down this process. So this is our in-house testing that we've developed, and on the bottom here, you'll see the number of hours it takes for the test to come back, and then the number of records on the left side. So with our amazing lab, they were rapidly able to develop in-house testing. This made a big difference for us. You know, you can see 9, 12-hour turnaround times on the COVID-19 testing. So here's some of our data most recently. So blue represents the negative results, and orange is the positive results. And what you'll notice is there was potentially an upward movement, and now we've flattened out a little bit, but it'll be interesting to see where this data goes. And this is university-wide UK healthcare testing results on this graph. And our total number of tests sent as of yesterday was 1,887, and we've had 70, that was the negative results, and the positive results was 70. So it was about 3.5% was what we were getting. We've had 70 positive results. And then on the inpatient side, as of yesterday, we had 7 inpatients with COVID-19. Here's geographical representation of where our screening has been positive. If you'll notice, Fayette County is the most number, and that makes sense. But we've had 47 out of 1,232 that tested positive in Fayette County. and this is 4% positivity rate so far up to today. If you also notice in Scott County and Jessamine County, there did appear to be maybe more common results as well. And then the eastern part of the state, it does appear that we do not have at least large outbreaks, and from what the data that we're gathering so far from UK. This is interesting if you look at the positive rate of the patient by age. So if you're 80-year-olds, we're at 8.6%. That would screen positive on our screening test. And then over 80 was 5.9%. Obviously, these numbers are concerning, considering the mortality risk with older patients with COVID-19. If you'll notice on the pediatric side, less than 10 years old, much less common, and that's after several hundred tests have been sent. And then from 10 to 20-year-old, there's 4.1%. So on the pediatric side, we are seeing COVID-19, but it is less common at this point. And this is data from our emergency department. So just a reminder about the mortality of COVID-19 with age. The case mortality rate of over 80-year-old was 52.5% in this Italian review of cases, and 70 to 79 was 35%. And there's descending rates of mortality after that. So something to keep in mind. And then this graph actually scares me a lot for our population. If we think about the comorbidities and if they increase your risk for bad outcome, COPD, cancer, diabetes, hypertension all had significant increase, as well as if you had just one comorbidity or more than one. And that does keep me up at night with our population here in Kentucky. Looking at the ED only data and our screening positivity rate. So you'll notice that fever only is comparable to cough, fever, and shortness of breath. So fever seems to be the most common symptom that's testing positive. What we'd like to communicate on this graph as well is a few things, but shortness of breath alone, we had been testing and getting zero results for that. It seemed like you needed something else besides just shortness of breath. If you look at, the other thing is if you look at none, so they didn't have fever, objective or subjective, cough, or shortness of breath, they were still testing positive at 2.5%. This is very concerning to us because these patients wouldn't be screened, they would come on back, they wouldn't be put in isolation, and they would be at risk, put our healthcare workers at risk. So we were very concerned about that number, and it's probably even lower than or potentially even higher than what's reported, because this is at the time providers who were ordering the test based on their clinical discretion. So we were concerned about that. So and that's UK ED data. So if you remember, the 29% of initial Wuhan patients were healthcare workers. So this is something that we really wanted to address. So what we did next was we looked at the largest review of cases that's been put out there, and this is 1,099 cases done in Wuhan, China. The average age of these patients was about 47 years old. Fever only was about 43.8% on admission, and they did define it as 99.5 or above, so even a lower threshold. But you would still miss a lot of patients if you only screened for fever. So what we did on the 31st was we expanded our criteria to fever, subjective or objective, cough, shortness of breath, sore throat, myalgias, chills, loss of taste or smell, and unresponsive. And we did this using the prevalence data from the largest case study of symptoms. So we added the loss of taste and smell because the University of Washington actually uses this as a screening criteria, and also there are reports of this being a more specific finding. So we've added that as a symptom to be aware of with COVID-19. So this would send the viral respiratory panel, COVID-19, and place the patient in isolation precautions, protecting our healthcare workers. So we updated our algorithm a few days ago. We've expanded the criteria to protect healthcare workers, identify inpatient persons under investigation, and identify and isolate community persons under investigation. With our system that was already in place, it seems to be working well so far. I will say we haven't actually ordered more tests so far, and I think that is a result of as our providers were concerned about COVID-19 and other patients, and they were ordering the tests otherwise. So automating it didn't increase our use of testing, but we are keeping a close eye on supplies, swabs, and tests. So looking forward toward our respiratory pod, this is a schematic of that. So what you'll notice is the key concepts. So our forward triage plan. So we actually have a pivot nurse who meets the patient at the door. They will screen the patient for any of our possible expanded criteria. They'll go ahead and send the patient on back to the respiratory emergency department. Now, the idea here is to set up a hot and cold zone in the emergency department. So the hot zone has any possible patients that could have COVID-19, and the cold zone is the rest of the emergency department. The cold zone, we're still wearing our mask and eye protection. That's a surgical mask and eye protection at this time, because that's still considered a low risk, it's low risk even if you do have a COVID-19 patient. Back in the respiratory pod, though, we are using more full protection, and I'll explain a little bit more about that. So our goal here is to limit the number of contacts with our patients and then protect our healthcare workers. And we're also going to preserve PPE. Now, how we're going to do that is we're actually going to use telehealth, and I'll explain a little bit more about what we're doing with that. So here's a schematic of what we've started in the emergency department. If you'll notice at the top, the pivot nurse will do an in-person exam at the very beginning. They'll have full PPE on. They will screen for our expanded screening criteria. Our labs will be sent. The patient will go around the outside the emergency department into the respiratory unit. At that point, they'll be seen by a physician in triage. This could be done via telemedicine or via in-person exam. And then they'll go down to the respiratory pod and either go through a fast track where it's just like swab and discharge, or they'll go to main track. All the 24 rooms in the back of our pod zone are going to be equipped this week with telehealth and be able to have all those remaining interactions via telehealth. I would like to emphasize too that we are using telehealth for registration. We're using telehealth for social work, for nursing, and really any interaction that could be done in person can be done via telehealth. So our critical care patients will be activated along the right side of the screen, and that's a different protocol for us. So what are we doing with discharge? So our pharmacy staff will follow up on the results that are put into REDCap regarding who to call back and how to call them back. And then they're making the call back shortly thereafter. This is actually working pretty well. With positives or negatives, we call the patient back and give them appropriate instructions. We've also worked with UK Telecare in coordination with urgent care, but also with the UK telemedicine system that they've implemented, and they've already set up thousands of appointments for patients. This is very impressive that they've got this done so quickly. So telehealth in the emergency department, this is a rapidly expanding issue. The CMS has markedly decreased their restrictions, and they've lifted them during this public health emergency. So what we've done is we've outfitted our back 24 rooms in a respiratory pod with iPads and have them available for telehealth. So Good Samaritan and the PEDS emergency department will also have telehealth as well. So the nice thing is that all providers can be on the same screen at the same time. So you could have nurse, you could have an APP, you could have a physician. It actually improves communication, but we're also very markedly limiting our PPE through doing this. As you can see, you can have them available to listen in on the screen. So this is an iPad stand and an iPad that we put up. You'll notice that it's actually pretty easy to clean, and we'll do that in between patients. So our goals here are limit PPE, and I think we can markedly decrease our PPE with telehealth. We're going to work on contact time and limiting that with patients. We have access to subspecialists that can that can do the telehealth as well. And then this could potentially allow quarantine doctors or nurses or other professionals to actually work from home. And so I think all these are wins in the emergency department. So briefly, I'll talk a little bit more about our airway management pathway. So this is the pathway that we're currently using. A lot of this will probably be adjusted here in the next few weeks and month as well. But I'd like to emphasize some key principles. Principle number one is to minimize the aerosolization. So just remember that these are high-risk procedures, and we take that from the SARS data of people that got infected after doing the procedures. These are difficult intubations. So there's this concept out there of happy hypoxia, where the patient is actually looks great and they're talking to you, super alert, not working hard, but then they're hypoxic and their stats are tanking. So it's this happy hypoxia picture. There's controversy about should we intubate these patients because there may be evidence that they actually do worse on the vent. But there's also the side that you don't want to be doing a crash airway at any point with how long it takes to get PPE on, and you want to be able to protect your healthcare workers. So a lot of people are actually emphasizing intubation early with these patients to better protect healthcare workers primarily. So the other key principles with minimizing aerosolization are having these patients in a negative pressure room, making sure you have complete airborne precautions, including powered air purifier respirator versus N95 if you have N95s as well. And then hooking these patients up directly to the vent with a viral filter in place. A lot of this you can find online. There's some good resources out there. Importance of maximizing first pass success can't be understated. So importance of identifying an airway team, having the most senior person possible, most experienced person do the airway. In our shop, that could be a resident actually who's been doing airways, their whole residency, maybe more than attending, but we let the attendings make that determination. And then another key point that's got to be emphasized is using video laryngoscopy if you have it available. You'll have a little more distance between you and the patient, and you'll be better protected in that way. Also, likely a better likelihood of success as well in the procedure. Reducing personnel exposure. So fewest number of people in the room is what we've said. We want our spotter outside the room to help as well. The spotter is very important. I had 2 airways yesterday that I went through the full protocol, and after you do the procedure, you actually may not be as aware of the doffing procedure. Just remember that during the doffing procedure, you're actually at the highest risk of contracting COVID-19. So you have to do this safely. Having a spotter outside the room is key, somebody that can actually walk you through the steps. Because you may not be thinking about as clearly after you manage the patient, you've done the procedure, those kind of things. So walking through those steps is vital. This is a schematic of basically what we're doing as well. This is from Italy, but you have your primary intubator at the head of the bed. You've got your nurse and your respiratory therapist in the room. Everybody else is outside the room, so you'll notice we'll typically have our pharmacist outside the room. We'll have our backup intubator outside the room, unless they prefer to be inside the room with full PPE on as well. And then you've always got your spotter available as well. So thinking about this more globally, we know that from Seattle, we know that we'll get through this. While there's a lot of concern and anxiety among patients and staff, we have also seen tremendous resolve and courage. So overall, I think our goal here at the UK Emergency Department is exceptional care for patients, but also just keeping our healthcare workers safe. And we really want to do that and also preserve PPE moving forward. So I think, I think the emphasis is on we'll get through this. And the EM providers are probably the best prepared, at least on the front lines for this, and we've been preparing for this. So I think we can do it. Some acknowledgements as well. The COVID-19 Emergency Department leadership team. I'd like to acknowledge our frontline staff and in the nursing department at UK. Dr. Daniel Moore set up the hepatitis C screening program that we've rapidly intimated into an automated process, and he also works with hospital operations. Dr. Humphreys is our emergency medicine chair. Dr. Forrester has been working nonstop off the clock with infection prevention and control here. And then my sister-in-law is Mallory Hunter, who helped me out with some of these slides. So with that, I'll pause here and leave open to discussion and questions.
All right, so we have several questions online. The first is, how are ED clinicians differentiating acute allergy symptoms versus COVID-19?
That's a good question. We've debated back and forth. If you'll notice, back on the Wuhan data, rhinorrhea was 10 to 15%, I think, on the common symptoms. So we actually didn't include rhinorrhea on the algorithm, mainly for the issue of this being a lot more common in allergy symptoms. I will say though, at least in our emergency department, I know a lot of places can't do this, but our goal is to identify as many possible people as possible, just because we have the system set up to be able to do that. So we're going to overscreen a lot, potentially, but on the backside is we're going to protect our healthcare workers and do what we can to do that. So.
Okay. Do you prefer that symptomatic patients call the ED before arriving? If so, what is the correct number to call?
I think if you're symptomatic, you wouldn't have to necessarily call ahead. It's not like setting up appointments. I will like to emphasize, though, that we aren't doing asymptomatic screening in the emergency department. And that's just a decision that we've done. A couple other options for you if you're here in Lexington. If you're a healthcare worker at UK, they do have a setup at Turfland for patients, and they potentially will expand that to more groups to screen at a later point. But if you're a healthcare worker, you can go there. And then also you could also look into the urgent care opportunities that are available via telecare with family medicine here. I think that's also a good opportunity.
So I have a question here asking, if we get exposed today, how long should we wait to get tested?
Well, if you're asymptomatic, then you wouldn't need to be tested right away. And then obviously, the other point is if you are symptomatic, but you have very mild symptoms, you can just stay home and follow the guidelines as well about being quarantined for 14 days since the exposure. So the test parameters I've seen all over the place. There is likelihood that you will test negative on the PCR if you're tested early in the disease process. So if you do end up getting tested, you may have a false negative. You should still follow the guidelines about quarantine.
Is there evidence asking about the GI issues?
Yeah, this is I've seen 2 patients personally with diarrhea that had COVID-19, and we've debated the GI issues back and forth. If in the large study from Wuhan, diarrhea was only 4% positivity rate, but I'm suspecting it will end up being higher. The other thing is from pediatric studies, we've also seen that GI issues are more common. So that will be something to be more aware of if you have a child with GI symptoms.
Some of the Chinese data suggests pneumonia, as evidenced on CT scan prior to people being PCR positive. How can this be considered? Is the assumption that they're hypoxemic?
So the CAT scan is positive before the PCR test. Is that what they're asking, Kim?
I believe so.
Okay. Yeah, I've seen that as well, and that's why we initially did the CT chest kind of early March as a screening tool, but we rapidly removed that due to the risk of having radiation to the patient, and also having to clean the CAT scanner after every intervention. So once we got access to the lab, we stopped doing that as a screening test. I'm actually not sure about the pathophysiology about why the CT chest will show up before the PCR test. But that might be a good question for infectious disease colleagues. I haven't actually heard that what that would look like. So.
Someone else asked, and this may also be a question for ID, do we have any information about how many false negative tests we might expect?
Yeah, that's a good question as well. I can't tell the specific numbers on that. And I think part of that would depend on the prevalence in your community and your negative predictive value as well. So that'd probably be a good question to ask your local infectious disease expert.
So I've got a whole bunch of questions around testing asymptomatic people, whether it's parents bringing their kid in who may have tested positive, whether it's frontline healthcare workers who may be asymptomatic. Do you have any comments about those?
Yeah, we are not doing asymptomatic testing in the emergency department. The guidelines nationally are not to do that as well. I think if you're asymptomatic, the best thing is just to avoid people that could be at risk, and just to stay home, kind of like the typical guidelines that we see. The healthcare workers, that's a special group, but I would talk to your local institution about what you've developed as your protocol for that.
So we have a question about method of transmission. If COVID-19 is spread by droplets, why is there so much emphasis on N95 masks and airborne precautions? Can you explain further how the virus may become aerosolized?
Yeah. So agreed that it does look like it's mainly droplet spread. The airborne risk in the emergency room, though, is probably the highest of any place in the hospital. And so with patients that are undergoing nebulized procedures, they're undergoing intubation, there is airborne risk. And we know that from the SARS data as well about patients doing those procedures getting infected. So there is risk. We've elected to take an extra layer of protection to protect our healthcare staff, because we'll be using less PPE via telemedicine and separation of patients. So that's why we elected to use the additional airborne precautions. But you're right, the national guidelines are droplet alone for most patients, or just eye protection, contact, and droplet are the guidelines.
So we have a comment, nice presentation. Given that it looks like 20 to 40% of patients have minimal symptoms and false negative rate on PCR tests is approximately 30%. Do you anticipate changing your protocols? Also, do you anticipate using recently approved GIGM tests to screen your healthcare workers? And using those who have IgG positive as more frontline workers.
Yeah, so I'll address the serum question, the antibody test first. That is hopefully in the works soon. We do have the capabilities to do it. Our infectious disease specialists are working on that issue. As far as screening, we are trying to identify as many people as possible. We agree that there are false negative risks, and we'll actually give them recommendations that still to follow the national guidelines regarding quarantine, self-quarantine, and such. So, but I think identifying as many as possible, especially for our admitted patients, is the key.
This one's interesting. If someone has to go to the hospital for non-COVID related reasons, would you recommend them self-isolating for 14 days after their visit anyway?
That is a good question. I have not seen that recommendation anywhere. I think, especially if your emergency department is set up in a code zone, hot zone, or they have taken precautions regarding at least attempting to separate patients, you should be okay as far as not having an exposure.
The next question is, if 4 to 8% of tested patients are positive, what precautions are you taking in the ED triage room to protect those who have symptoms but may not have COVID from getting it, protect them from getting it there?
That's a really good question. Our nursing staff has been very proactive about protecting our healthcare workers. I think the forward triage is a big point here. I've seen some departments actually have somebody outside the door and divert people with symptoms to a different route. We meet them at the door. I think, and we actually don't even go through our triage room in the front. We go straight back to the respiratory pod. So I think the biggest thing is early identification and triaging these patients to the appropriate respiratory pod and isolating them in some way is the way to really prevent this up front. Oh, I will say too, we actually have some of our most experienced nurses on the front line as the pivot nurse. And I think that's key as well. If you can get somebody out there very experienced who can identify infectious versus non-infectious symptoms.
The next question is, I know you mentioned that if we keep the curve flattened, that this is expected to peak in mid-June. Is that just here in Kentucky or the US in general? Is this taking into consideration social distancing guidelines until June? Could you elaborate on this a bit more?
Yeah, so this is all over the place, honestly. That was the most recent update we've heard from town hall meeting with Dr. Newman, and they're taking into account social distancing, kind of our exact patient populations, all the potential kind of factors, and they have epidemiological experts looking into all this. I think all this could change tomorrow, but it's that was the most recent update we've heard. And that data was for Kentucky specifically. So, and if the earliest we've heard is late April or early May, it does seem that consensus is that we're getting the peak pushed back some. Now, I also mentioned that even though the peak will be pushed back, the area under the curve, or the total number of patients that we'll see, should be about the same. So I think we still need to be prepared either way. We definitely need to be prepared for a surge as soon as possible, just because we can't predict exactly the future.
How are you finding patients are responding to telehealth? Are you finding that it increases anxiety?
So far, we've had good responses. We haven't had a lot of patient interactions via telehealth. We're actually outfitting our whole pod today. Actually, we'll be working on that, but over the next week or so, we'll be outfitting it. We've been mainly using it in physician and triage area. We are concerned about a couple issues. We're concerned about patient anxiety and not making the patient feel isolated. So we will need to address that. As a good point. The other thing we've thought about is patient privacy and making sure we're following HIPAA guidelines. That also will be an issue moving forward. And I think everybody who's doing telehealth should consider that. And then I think that those are probably the two biggest things that we've thought about as far as risk with this.
Right, and Cliff K just mentioned for folks that Dr. Newman's next town hall meeting will also talk more about the epidemiology and the expectations from UK's epidemiology team.
Perfect.
So we have a question about the other viruses that are circulating right now. So if only 4 to 8% of symptomatic patients are positive, what else are you seeing?
It's interesting. Since we've been sending the viral respiratory panels, we've actually been able to identify a lot of patients that have different viruses, and often it's actually multiple viruses. For example, we had lots of patients from the Hope Center for a stretch, and we identified flu outbreak there by doing this, and also they would have like adenovirus. Other species of coronavirus are also present that we're seeing. Just remember that the coronavirus screen on the viral respiratory panel doesn't correlate with the SARS-CoV-2 virus. So you have to, you still would have to order those tests separate. But definitely coronavirus, adenovirus, probably the top two, and then the flu. Though I will think that we have been seeing less of flu over the last few weeks.
The next question is, I have seen a lot of people in the community making PPE to try and help the shortage, such as masks made out of fabric. Are these useful as PPE? Are there other options that the community could do to counter the PPE shortage?
Yeah, I've also, I've basically constantly getting people offering me to make a homemade mask. And unfortunately, the cloth material just isn't good enough to prevent droplet spread unless it, if it's all you have, it's all you have. But the surgical mask and it would be a lot better. As far as opportunities for people in the community, I think one thing that happened to me that was I had 4 different nail salons here locally in Lexington offered to give me their mask, and so these were like medical grade masks. And so we've had a lot of outreach from people at UK in different departments as well. So if you do have access to something medical grade, whether it's N95 mask or surgical mask or anything else, I think it's reasonable to reach out to a healthcare provider to see if we can use it.
We have a question about the discharge criteria and the kinds of tests you're using, respiratory PCR or viral swab and culture.
So the respiratory PCR is the viral respiratory panel that we use, and it identifies multiple different viruses. So originally this was set up as more of a affirmation system to patients to tell them, well, we tested positive for this. You could still have a co-infection, but at least you do know that you have this. And then also for epidemiological purposes, because we want to identify as many co-infections as, or identify the co-infection rate, et cetera. So that was the thought behind that.
Do you know if other hospitals in Lexington are implementing similar ED protocols, and how much communication and collaboration is occurring amongst different hospitals' EDs?
ED, I think we're doing really well with collaborating. I've talked with Mark Spanier at Central Baptist Medical Director several times, and Mark Sloan as well at St. Joe, Maine. And I think we are all in this together, and we definitely need to collaborate. the screening availability, in my understanding, isn't as available to other hospitals in the region. And we are fortunate to have set up the in-house laboratory with the faster turnaround time. So, but those hospitals are doing an outstanding job from everything I've heard.
We got another comment from Cliff K, who says to contact Takia Talbert or Lacey Buckler if you have community members interested in making masks. They have a prototype and instructions that they want folks to follow if they want to make masks.
Yeah, I love that. That's great. I'll have to get that information from her as well. I wasn't aware of that.
Okay. And that looks like we're through the questions. Any others before I let Dr. Hamm go? Okay, I'm going to put up the image, and that doesn't mean anybody can't also continue to ask questions. But I'm going to put up the CE Central. Move the chat window. All right, so it looks like we have one more question, but here is how you go to claim credit. Go to cecentral.com/get-credit. Deadline is June 1st. There's the credit code. And I am trying to get down to those new messages. Okay. So people are asking about the presentation being available. This particular meeting room only had 300 people in it. So we will have the presentation up and running online for today only so other people can view it. Because it will be out of date quickly and everything is changing, we are hesitating to keep this up in any enduring format long term. Just because I don't want this to come back to Dr. Hamm, in 3 months saying, but you said, well, he said that 3 months ago.
Yeah, this is rapidly changing. Over the last couple of weeks, we've adjusted things so many times, and it's going to change again. I think we all have to be dynamic in this process.
So we do have another question. Is it true that NSAIDs prevent the body from producing proteins needed to fight COVID-19?
I've seen that as well with the NSAIDs, and it goes back to the ACE2 receptors that are affected as well. I'm not a pharmacist and couldn't talk about the pharmacology. I will say the data hasn't been great for this so far. There'd be something to talk about again with your ID physicians about what your institution wants to do, but I don't think this is prime time yet.
And we do have a few more patients, but in partial answer to that, this series will continue for the rest of April on Fridays at noon. Next week, Dr. Moorhead is going to talk about ARDS. The week after that, we will have a pharmacist talking about some of the drug considerations.
Yeah, that's great.
And then Dr. Connie White from DPH will talk the final week in April. Okay. So after someone tests positive, have you heard how long someone is considered infectious, requiring PPE usage, and when we can safely say that they no longer need isolation?
So basically the guidelines are 14 days from quarantine, and then after they test positive, it's basically based on symptoms at that point if you do a non-test based strategy. So what we've said is 3 days after all symptoms have resolved, that would be the time to no longer isolate. The other thing is if you do a test-based strategy, it's you need 2 negatives, I think, but that's on the CDC guidelines. And then so 1 to 8 days, I actually haven't seen that, but I have heard about asymptomatic spread and shredders. So I think a lot of this data was ongoing, and we're going to have to keep looking into it.
Then we had someone asking about testing zinc in these patients.
Yeah, I've seen that as well. We have not been testing zinc. I think zinc's interesting in low resource settings. It's actually used as a treatment for patients with, especially kids with diarrhea, because they're so zinc deficient. If you have a very malnourished person or at risk for zinc deficiency, that would be a consideration. It's probably not as common here, but it might be something to think about.
And then we have a question about whether we develop immunity.
Again, I've seen multiple things on that as well. There does appear to be some immunity developed, but it may depend on the amount of viral load and like your response to that. But that would be a good question for ID. Kim, we may want to have an ID doc on here at some point.
I've asked them. I'm going to try and get them towards the end of May, but as you know, they are all hopping right now.
Yes, they're busy.
So, but yes, I agree. We will do our best. So are we anticipating waves of COVID similar to the 1918 influenza?
I think I've seen that as well. It'll be interesting to see what happens in China now that they've flattened the curve and controlled the disease. I know they've cut off travel restrictions, but it'll be interesting to see what happens there. I think we could kind of go off of that once we see some evidence of what's going on in China.
All right. Any last questions? I'll give people a couple minutes to type. I'm not seeing anything. Thank you very much, Dr. Hamm. That was fantastic.
Yeah, thank you so much, Kim, for having me, and I wish everyone the best as you deal with this.